Hi, everyone. I'm Karen Borgstrom, the Director of External Affairs for Dartmouth-Hitchcock, and I'll be moderating today's panel. Thank you so much for joining us today for a discussion for those who have concerns about the COVID-19 vaccines and have questions about the safety and efficacy of the vaccines. Before I introduce our panelists, I just wanted to remind everyone that we are streaming this video today, this webinar today, because we're using closed captioning and we want to make sure that everyone can see it. And we're recording the event so that our colleagues who cannot watch the event now will be able to watch it later at their convenience. We'll post the link on the intranet after the event. Your participation in the event is confidential and your questions will be anonymous. We're excited to have 4 panelists today who will share information, listen to, and hopefully answer any questions and concerns that you have. With us today is Dr. Phil Adamo, Dr. Jose Mercado, Mike Harhen, and Marilyn Hill. Dr. Adamo is the Chief for Occupational and Environmental Medicine. Hi, Dr. Adamo.
Hello.
Give me a wave. There we go. Dr. Jose Mercado. Dr. Mercado is an associate hospital epidemiologist and is the COVID-19 response leader. Dr. Mercado, give me a wave.
Hi.
There you are. Hi. Mike Marhen is a medical technologist certified by the American Society of Clinical Pathologists and is the Senior Director of Pathology and Laboratory at Dartmouth-Hitchcock. Mike, hello, welcome.
Hello.
And Marilyn Hill is a doctor of pharmacy and has a master's in healthcare administration, and she is the manager for the DH Ambulatory Pharmacy. Hi, Marilyn.
Hi.
Hi. So if you've tuned into this webinar about the COVID vaccines, it's because you have questions, and we really do want you to take some time with your questions, and we'll make sure that you do get the answers to those questions from our panelists. However, if there are questions that are not answered, or if we can't get to everybody's questions, please use the HR info line at Hitchcock.org and put your questions in there, and hopefully you will get a quick response back if questions are not answered. So with that, we're going to hear briefly from each of our panelists about things from their point of view that might be of great interest to you. And so we're going to start off, I think, with Dr. Adamo and have him tee things up, and then we'll go through the panel, and then we'll open it up to questions. Dr. Adamo.
Great. Thank you. Good afternoon, everybody. I'll just give you a little bit of a background for me. I have been both an occupational health or occupational medicine physician and an internist all of my professional career, more on the occupational side. And I've been involved with public health, or what we call population health, for a number of years, and there are always challenges. We had the H1 epidemic in 2009. I had chemical exposures in Pittsfield, and one of the things that I really feel proud of is that I listen to people and get people to get their fears and their questions taken care of. And at the end of 10 years of tenure, I was able to gain the confidence of the community. I also want to talk a little bit about smallpox and vaccinations. So vaccinations are the #1 public health accomplishment in our modern day world. Now, smallpox was in 1777, 300 years ago. And the first mandated vaccine was for Washington's army. And it wasn't really a vaccine, it was variolation. And just to let you know, there was a lot of hesitancy then. Ben Franklin was against the vaccine until his youngest child died from smallpox. George Washington was also fearful that the enemy would use it as biologic warfare. So again, history repeats itself. And I would like you to think about the history and how it can have an impact not only on your life, but the lives of those that you love, and for patients if you're doing patient care. Thank you.
I should never mute myself if I'm the moderator. Thank you very much, Phil. All right, let's shift over to Dr. Mercado. From your perspective, Dr. Mercado, what are the important points you want people to take away from this webinar today?
Yes, thank you. I wanted to share some recent numbers that pertains to the vaccine effectiveness as well as safety. As far as effectiveness, one of the more recent studies from the UK just shared that after you get the vaccine, you reduce your risk of getting or developing long-term symptoms by more than 50%. You reduce your risk of hospitalization by more than 60%. And you are twice more likely to be asymptomatic with the vaccine should you have a breakthrough infection. When it comes to safety, a recent study that looked at the adverse events reporting system showed that out of about 9 million participants, only 0.1% developed adverse effects, and 90% of that 0.1% only really had non-serious side effects such as dizziness and headache. Lastly, when you compare maybe more serious or potential serious adverse effects with the vaccine as to compared with COVID infection, another study had shown that not only does COVID in and of itself put you at risk for things like myocarditis, clots, heart attacks, and strokes, which in essence, getting the vaccine reduces or protects you from developing these complications should you get the COVID infection. Thank you.
Thank you very much, Dr. Mercado. All right, let's shift over to Mike. Mike, your position puts you in touch with many DH staff. Are there some insights you'd like to share about the concerns they may have about the vaccines and any other information from your perspective as the person who is really hands-on at the lab that you can share with the audience today?
Yeah, Karen, it's been a really interesting, the last 18 months have been like I've never seen it. I have the privilege, along with Dr. Wendy Wells, of leading an amazing team of laboratory professionals. And Dartmouth-Hitchcock, the lab team here, was able to come out with the first hospital to offer testing in the northern region. And that was like early to mid-March that we did that. And we had that test. And then volumes increased and we needed to move to a different platform called a high throughput. We had done that. And then everyone, Phil and Jose, everyone was saying, Mike, we got a test, but now we need a faster test. So we came up with a rapid PCR as well. So first of all, I want to say to my team that they've been absolutely amazing in their response to this. And I had little to do with it. They did all the hard work, and kudos to them. I do understand the confusion because we in the lab were confused. This was a novel virus at the very beginning, SARS-CoV-2. We didn't know much about it. The little that we did know about it, we put plans in place, mitigating factors in place. Steep learning curve though, and as quickly as we learned more, things had to change. So there was a lot of change that was occurring rapidly. And I feel like it was hard for my staff to keep up with all the changes as well as me. And I was on the incident command, and but the changes were communicated. But when that happens, it was a fair degree of uncertainty with change. And so I understand everyone's concern and confusion based on the past 18 months we had as a backdrop that might be on the fence with this new vaccine against a new virus. But the fact of the matter remains that viruses, even SARS-CoV-2, the characteristics are the same as other viruses. If the spread goes unchecked, the virus will continue to mutate, will continue to get deadlier, as we're seeing that now with the Delta variant. And I'm sure there are going to be other variants coming along that are even worse than the Delta variant. We also know that the best tool, as Phil had said, with these deadly viruses is vaccination. Vaccinations stop the spread of the virus. When you stop the spread of the virus, you can stop the mutation and get a handle on it. So having said all that, it's been a very difficult 18 months, but I hope people attending this call can get their questions answered and be convinced or be considering all the options, choose vaccination. That would help everyone.
Great.
That's it.
Thank you. All right, and Marilyn, from your perspective in the pharmacy, what information do you want to share with your audience about the vaccines from your vantage point?
Yeah, so as a pharmacist, I can provide a little bit of insight on the regulatory processes that govern how new products get approved. Well, I've never worked for the Public Health Service. I did have a rotation when I was a student, so I understand some of the meetings and reviews that they have. Also, fun fact, all of the approval letters and details about each of the vaccines are public knowledge, so you can go to the FDA website and get more information. In order to be considered for an emergency use authorization, you need to have at least 2 months of data in the phase 3 clinical trials, which is the last clinical trial before it hits the market. And you have to demonstrate efficacy and a lack of safety, and that's even to be considered. So I think by the time they get the approval, they might have more data. And in the case of Pfizer, they have over 2 years of data. So people that have been enrolled, they get the side effects maybe with the second dose that are pretty mild, and there are no patterns of serious side effects of note. So I think the time to wait and see is dwindling. I know that some people have kind of wanted to see how effective it was and wanted to see if it's continuing to be safe, but we know that mRNA is a pretty unstable molecule. It can't be in the sun for very long. It can't be out of the freezer for very long. So we would expect that the effect it has on your body happens pretty immediately in the couple weeks after you get vaccinated. And I do not expect additional side effects to surface even a month out after vaccination.
Great, very helpful. Okay, thank you. There's a question that came in through the Q&A. It's for Dr. Mercado, but I think you all might have some input here. The question is, how many deaths due to COVID vaccinations have been reported to VAERS? I'm assuming that's an acronym for something that I don't know, but VAERS. How does this compare to other vaccines? We'll start with Dr. Mercado, and then maybe if any of the other panelists want to chime in, feel free.
Yes, that data is available at the CDC website. And out of about 369 million doses vaccinated, they do report through that VAERS system close to about 7,000 reports of death, which is a rate of 0.0020. It is important to note that these reports of adverse events do not necessarily mean that the vaccine had caused a health problem. This is essentially more of a temporal association. I believe that this number also, in comparison to other vaccines in general, based on what we know so far, it is more reassuring than the general rates of reported deaths that are temporarily associated with other vaccines.
Okay, let's shift over to Marilyn. I'm sorry, go ahead, Phil.
I was just going to say that we make it a little bit easier if an employee during our surge received a vaccine and they thought they had a side effect that's not listed, we would complete the VAERS for them. So again, when you get the vaccination, there will be information on what to do and who to call if you feel that something different has happened to you.
Thank you. That's helpful. I'll go over to Marilyn. From a pharmacy point of view, you might have some good feedback on that question.
Yeah, I'll also add, think of the VAERS system as kind of like our OWL system. It's voluntary. They definitely want to collect the information so that they can then do something with it. But just because it's reported does not mean it is an issue that is related to a causal relationship. We know that there could be a correlation, but you have to unpack what are the natural deaths that are occurring? What are the normal epidemiology of the various disease states that the population could have on a chronic condition basis? So I would caution using VAERS in terms of number of side effects reported, just like you wouldn't count the number of safety events reported, because it's not fair to judge the number and volume in that case. I can promise you that all of the things being reported are going to be investigated by either the manufacturer, perhaps even PhDs at the FDA. That's all going to be looked into to ensure that we don't have a real concern on our hands, but the raw reporting itself is not where we should be concerned at this point.
Okay, understood. Dr. Adamo, if an employee has a question about the vaccines that are unique because of their particular circumstances, what's the best way for that person to get answers to his or her questions?
They should start with their primary care provider who knows them the best. They know their history, they can guide them. You can also reach out to the HR info line. And even if it's a medical question, occupational medicine is part of HR, and the person who runs or manages the HR info line will send the questions to us and we will get an answer for you. If you call Ahmed, it just clogs the phone lines and nobody wants to be waiting online. So I would advise you to write the question out and send it to hrinfoline@hitchcock.org.
Great. Okay, here's a question that came in on the Q&A for Marilyn. Does DH have in its possession the new FDA approved Pfizer vaccine? I'm curious about which Pfizer vaccine is currently being utilized.
I believe so. My role is not specifically in supply chain, but I thought I read in those emails that if you're an employee looking to get vaccinated, you can mark a preference for the Pfizer vaccine. And I would say that there isn't a distinction between products of emergency use Pfizer vaccine and the new vaccine. It's always been made the same way. It's always been manufactured the same way. They just have continuing studies that have now been blessed by the FDA with a full approval. But the actual, product itself has not changed, which is why we can have some certainty in the other emergency use authorization vaccines, because they've all gone through the same thing. The other companies are just a little bit behind and haven't gotten the full approval yet, but nothing's going to change with their products.
Thank you. And Dr. Mercado, that's a good segue to sort of the distinction between full approval and what the FDA had done for Pfizer and Moderna before. And I guess Moderna is still in that sort of preliminary approval stage. Can you talk about the differences in the FDA approval process and what those mean for people?
Yes, the emergency use is really to allow us to address a public health emergency. It is the approval for emergency use is based off of the best available evidence. So it does not mean that a product had been rushed or they have cut corners. They've met the requirements and they've been allowed to kind of remove some of the administrative barriers so that we can help the community at large. Once you have full approval, meaning you've completed the rest of the administrative requirements, a fully approved vaccine just really allows you to market your product. And that, I think the hope is that for those who hesitated because the product is not fully approved, we're hoping that those individuals may now have some of that reassurance to get the vaccine. And the other would be, it's hard to get the information that you need depending on what resources that you have. So a fully approved product, having that ability to market that product will hopefully reach those people who have not had that information when it was under emergency use.
Okay, that's very helpful, I think. So this is for Mike. So DHH's requirement to get the vaccine is based on science, which is what we've been talking about since the beginning. What do you say to those who are on the fence about the vaccine with concerns about the process and the results of the trials that proved the vaccine's effectiveness? Because those people still have questions.
Yeah, I would say continue to follow the science. Probably your primary care provider, if you can get in to see them or talk with them on a phone appointment, that would be the best thing to do. You're right, Karen, the laboratory is driven by science all the time, and we're held to strict regulations as well. Even some of the methods, the commercial methods of the testing that we're using to either diagnose, as well as we actually have 2 antibody tests that actually will measure the immune response of a vaccine. All of those methods were emergency use authorization as well. So we're not just talking about the vaccine. Even the diagnostics were emergency use authorization. So we do have a habit of following the science and following regulatory requirements. We don't dig into social media to get our answers. We dig into journals. We dig into the CDC website. That has a wealth of information versus social media platforms and the like. So I would really encourage people to get their answers from healthcare providers that they know, or ACMED, or doing their own digging and visiting the CDC website and getting their answers there.
Great. There's a question that came in from the Q&A for Dr. Damo and Mercado. What is the reason behind the face shield? We've been conducting daily operations with vaccinated and unvaccinated staff, patients, and visitors. We have only mandated that staff caring for COVID patients wear either a face shield or goggles. I have many staff members who have expressed to me that they do not understand why they have to wear a face shield now after all this time. Let's start with Dr. Damo. Can you take that one to start?
Sure. So again, if you look at the science and you look at what protects you the most, it is the shield, the mask, and 6 feet distancing. Remember, we are doing risk mitigation, not risk elimination. We can control the employees who work in our facilities. We can't control patients and visitors. And remember, the shield is to protect the unvaccinated, who are more vulnerable to getting COVID from a patient. Now, the shield does not, and we're going to clarify this because I found that people have a little misunderstanding, and you don't have to wear the shield coming into the building, or if you're going on a break and you're going to be by yourself, or if you're walking a hallway where there's no other people. It is the safest way. And remember, during the surge, we all used shields because we didn't have the vaccine. So now we have a vaccine. There are some vaccinated people who want to wear a shield also. We're not going to stop them. And so I think understanding, again, the science, that this is the most protective is the way we're going.
Okay. And Dr. Mercado, do you want to respond to that as well?
Yeah, I think Phil had explained it well. So I think the general concept is we are essentially adding additional layers of protection for the individual and for those exposed around them. So, you have physical distancing. When you wear a mask, we know that a mask is effective up to a percentage of level. And as you add those additional layers of protection, it becomes more and more effective in mitigating the risks of the individual getting the disease as well as potentially spreading it. So we just wanted to make sure that you have the best available protection.
Excellent. I'm going to send this one over to Marilyn and then Mike. Some reports suggest natural immunity is protective against reinfection. Why would the vaccine be mandatory even for individuals that have been previously infected, regardless that the vaccine is safe, such as having chickenpox and not requiring a varicella vaccine?
Sure, I can start off. From what I understand, and other panelists feel free to jump in, the immunity you might get from having the COVID infection naturally, well, first we want to avoid you getting the infection in general. We don't, if you're talking about unknown side effects, we don't know what happens as a result of having COVID itself. But if you've had COVID previously and you've recovered, and that's wonderful, you might have immunity for a month or two, but we don't know how long that lasts. We do know everything about the immunity that you get after the vaccine, and its studies are continuing to ongo. So I think it would be best if, even if you've gotten the COVID actual infection yourself, you do still need to get vaccinated to make sure that you are truly protected for the duration of time we expect.
Okay, Mike, anything you want to chime in on with that one?
Yeah, I think from what I've read, it is, as Marilyn said, it's about the durability of, you know, having been exposed to COVID and getting COVID, your immune response, we're not sure about the durability of how long that lasts. I mean, that's the big thing. So that's why we're requiring the vaccination, because most of the science is related to the immune response against vaccinated people.
And that leads me to ask Dr. Adamo and Mercado about boosters. Boosters have been in the news a lot lately. We'll start off with Dr. Adamo. What can you tell folks who are listening in about the discussion about boosters and whether they're necessary and available?
So boosters have not been approved by the FDA yet. I know that we received news from the White House that the White House was recommending boosters. The FDA is very adamant that if a booster is given, it is not using the online, not online. What's the word, Marilyn, that I'm thinking of? The
Vaccine registry?
No, not the vaccine registry, but it's offline. It's offline use, and we don't know enough about it to say yes, you need to get it. We do know that people that are transplant patients and have severe immunocompromise will receive a third dose. Again, science has proven that this is the way we protect our people. Jose, I don't know if you want to add anything more.
Yeah, before I go into boosters, as far as your risk of reinfection is concerned, the risk of reinfection from natural immunity is estimated to be twice that of a vaccinated individual. So your risk of reinfection is higher, you know, if you relied on natural immunity from a COVID infection. As far as boosters is concerned, it goes back to what we've been discussing. The one factor is the duration of, or the durability of immunity that the vaccine provides. We know from other vaccines that can have a tendency to wane. We have good data that it's durable and stable up to about 6 months, which is why we are considering that now, you know, that 6 to 8 month time frame, part of it because we're starting to see new cases, which is the other factor that comes into question when you're thinking about and talking about, do we need booster doses? Because as you have breakthrough infections or new cases, then you question, is this because of the durability of immunity, or is this because we have reduced vaccine effectiveness against the circulating Delta variant? So these are the things that the professional organizations will have to weigh. What we know so far is that the vaccines have continued to be very effective in reducing hospitalizations. So the vaccines have maintained a greater than 90% effectiveness in preventing hospitalizations. But what we've observed is with the introduction of the Delta variant and the relaxation of the mask mandates, we've seen new cases. So from about 90%, the vaccine effectiveness when it comes to seeing new cases had gone down to close to 80% or high 70%. What is reassuring, though, is that, one, breakthrough cases remain rare. And of those that had breakthrough cases, they still tended to be mild to asymptomatic. So those are some of the considerations when it comes to getting booster doses.
Excellent. Question from the Q&A. Looks like it might be for Jose. What is the current survival rate for COVID-19 infection, vaccinated versus unvaccinated patients? Do you have that data by chance?
Yes, I mean, the short of it is that when you compare, mortality data from COVID infection, I mean, I think we've seen it on the news. We've had millions of deaths, right? So I think one of the things to also note is that earlier in the pandemic, we were seeing a lot of our elderly immunocompromised being more susceptible to severe disease, long-term symptoms, as well as deaths. But what is concerning now, partly because of our unvaccinated population, is we're seeing that demographic change. So younger individuals with less risk factors. I've reviewed the deaths that are not necessarily caused by the vaccine, but that was one of the first questions. But again, deaths from the vaccines remain very rare or temporarily associated, not causally associated. They were estimating it at 0.002%. So when it comes to risks and benefits, your risks of severe disease and developing complications and risk of death is much higher should you contract COVID than compared to the vaccines. Your potential of developing any serious adverse event is very, very rare. I think, one thing to add to that too is what are your risks of getting COVID? And right now, since we have a lot of spread, our level of transmission in the community is estimated to be high. So your chances of getting COVID is really a lot higher than, again, comparison, you developing any sort of complication from getting the vaccine.
Okay. Another question.
Can I add something?
Oh, sure. Go ahead, Phil.
So, we all know that we have a short supply of staff, and keeping our staff at work to take care of our patients is of utmost importance. When people who are unvaccinated get COVID, they miss more days from work. And yes, they get paid, but again, it takes away from taking care of patients. And if we have to close services, it becomes a problem. And I think if we're all in this together and look at the better part of getting vaccinated, you might think again about your decision.
Okay. Does anybody else want to chime in on the question that was just answered by both Jose and Phil? If not, we'll move on to the next question that came in from the Q&A. What specific studies show that any booster is effective in improving immunity? Maybe Marilyn can take the first pass at that one.
Sure, yeah, I have not dove into the literature enough to be able to cite it offhand. I believe the CDC, and Jose, please correct me on this, I believe the CDC was recommending third doses for immunocompromised people, which is now why we're allowing it here at DH. That isn't necessarily a booster because those people couldn't mount the same immune response at baseline. So this is just another dose for them. It's not a booster shot. And as Jose mentioned, the clinical data for determining who needs and the effectiveness of a booster at what time frame is not yet completely crystallized enough to shape our current practice. It's coming down the line. I think we can expect it sometime in the fall here, but I have not seen any data myself. I don't know if anybody else could comment.
Jose or Phil?
Yes, I think there is, as Marilyn had shared, there is a lot for us to learn more about our immunity against COVID-19. But the general thought is that, and what based on what we know so far, is that additional doses would allow you to have more of those circulating antibodies that would then allow you to neutralize the virus. So I think that's the concept, is that for you to have enough of an immune response to fight the virus is what is the concept behind it.
Okay, excellent. So here's a question for Mike. From your perspective and with your large staff, why do you think that it's really important for staff, specifically staff, to get the vaccination?
Well, it's certainly important to stop the spread, obviously, as I said before, stop the spread to our patients that we want to protect. But I also think it's important to protect our staff. In the laboratory, every step of the process of the laboratory, whether it be from the specimen collection, that would be phlebotomists, the accessioning piece done by lab assistants, and lab assistants are also doing specimen processing, and the laboratory technologists that are actually doing the analysis. Every step along that line is critical. If we don't have phlebotomists or if we don't have lab assistants, then we're not going to be successful. And we also want to make sure they're protected in doing their work. As I mentioned early on, being the first hospital in northern New England to offer testing, there were a lot of hospitals that were looking for us to do their testing from. But before we did one test, we wanted to make sure our staff were safe. So we, with our quality systems manager, as well as environmental, it was John McCannis at the time, I think it's John Barino now, we conducted risk assessments and all the steps and the processes of how we were going to perform that test. We shared those risk assessments with the staff. We had discussions, we answered their questions, we made changes. We wanted to make sure all of our processes were safe. And to my knowledge, we have not had one lab tech doing over 250,000 COVID tests come down with COVID. So the vaccine is the same thing. The vaccine is going to provide protection to our highly valued staff, no matter whether a technologist or a lab assistant. I think it's critical.
Okay. Other questions coming in. This one actually could be answered by all of you, and I think it's a question that a lot of people had because the vaccines were developed quickly. I mean, I know they had been in research and development for some time, but they were then announced by the FDA pretty quickly, as vaccines typically go. So a lot of folks have a question about how can I be sure the vaccines are safe? So maybe Phil, can you take that one, and then we'll just go around the panel.
Okay. Well, once again, you have to trust the science. They didn't just make a vaccine and give it to people. This is not an experiment. They went through all of the phases to make this vaccine as safe as possible. So I think you got to trust the science, look at history, look at where we have been, where we were 300 years ago and where we are now, where science has improved. And yes, there are side effects, but there's a risk of getting COVID, which is greater, and you have a more likelihood of having severe side effects from the disease.
And Jose, that question, I think people are concerned because they may have heard somewhere that there's some impact on people's DNA, or there's something that, changes them physiologically. And can you help people to understand that the vaccine does not impact their DNA at all?
Yes, I think Marilyn had briefly shared that previously, wherein, these are really meant to be instructions for you to produce that spike protein that your body would then recognize and build immunity against, so that in case you were exposed to the virus, you would have those soldiers to fight the infection and prevent you from developing severe disease, protect you from hospitalizations and deaths. I think as we had been sharing, one of the things that we have benefited from with having this vaccine adverse event reporting system is that we are able to detect potential signals early. And when we do, we then investigate if the signals or the potential seriousness of the adverse events are real. One thing that I have previously shared, which is recent, is the risk of myocarditis with Pfizer. And what we know thus far is that if you were to get COVID-19 infection, you are about 16 times more likely to develop myocarditis compared to an individual getting the vaccine and developing myocarditis, which again continues to be a rare phenomenon. In addition to that, getting the vaccine, as I have previously shared, also protects you from other complications of COVID-19 infections, such as clots, such as MI, strokes. So I think the bottom line of that is that one, we continue to have safety data that reassures us that the vaccines are safe. And two, we know that we have placed systems such as our vaccine adverse event reporting system that works, that helps us identify potential serious adverse events early. Maybe one last thing about that myocarditis is that, for the patients who develop myocarditis from the vaccine, they improved over time or with treatment. Most of those patients also did recover.
Okay. Something for Marilyn here. I'm afraid to receive the vaccine because I'm worried about possible side effects. How can a person who is concerned about those know what they are and manage them if they do have some side effects?
Yeah, so I think this is very connected to the last question. So let's think about this a little bit. We know exactly what's in it. We know the mRNA, we know that there's some buffers to stabilize it for the couple hours it can be outside of a freezer. And there's nothing else in it. There's no preservatives. I promise there's no microchips. And so we know that it went through phase 1 studies, phase 2 studies, phase 3 studies for the emergency use authorizations, and now to full approval. They'll continue doing clinical studies as they do with every drug and device that is approved by the FDA. The people that are reviewing all of this data are PhDs, physicians, pharmacists, and there's teams of them. It's not just a couple people. These are the same experts that have reviewed every other prescription that you have in your cabinet, every other intervention from a medical perspective that your PCP or other doctors have recommended for you in the past. And so if you've been trusting our healthcare system, you got to continue to trust the data that we have access to. That includes the side effects. So in the letters, I have it pulled up right here. They list the side effects that you can expect from the second dose. And it's things that are far more innocuous compared to some of the stuff you might already be taking. And please continue to take your meds. That's not my message here. After your second dose, you'll probably feel really tired. You might have a fever. I had some nausea with it too. It kind of varies depending on your body, but take a day, go have a good nap. You can take some additional ibuprofen or acetaminophen, check with your doctor or pharmacist first, but some over-the-counters are really easy to help manage that, and most people recover the next day. So I would say it's not as scary as you might make it out to be, and it's definitely better than ending up in an admitted bed in the ICU on a vent as a result of COVID.
Okay, excellent. It's a question for Jose, or probably others. Looks like a couple of our panelists could respond to this. Can anyone comment on vaccinated individuals being able to spread the virus? If the hospital reaches 100% vaccination rate, are we still at risk to get infected and infect a patient that chooses not to get vaccinated?
Yeah, I can take the first stab at it. As I previously shared, the chances of a breakthrough infection in vaccinated individuals remain to be rare. It's not a common occurrence. No vaccine is 100% effective. So we can't guarantee that you would not get the infection. So breakthrough infections do happen. And one of the things that we know with the Delta variant is that, yes, you can spread the disease. But in comparison to unvaccinated individuals, those who had the vaccine had mild to asymptomatic infections and were infectious for a shorter period of time. If you remember that 0 to 14 days versus in maybe the general unvaccinated population versus maybe 3 to 5 days of being infectious or possibly transmitting the virus in vaccinated individuals.
Okay, Marilyn, do you want to respond to that as well?
I don't have any other additional information other than what Jose just mentioned.
Okay, and
Can
Mike, go ahead.
Yeah, if I could comment, where the early studies are coming out saying that the current the vaccinations, well, first of all, the efficacy of the vaccines, Jose, hopefully keep me honest here, given 90 to high 80% efficacy, was better than a lot of the traditional vaccines we had. The fact that the Delta variant, the efficacy is going down towards, the lower 80%, it's still very good efficacy, even against the Delta variant. With the 6 to 8 months where thinking about a boosters, because some of the immunization from levels are dropping off or waning, it doesn't mean that you right at 6 to 8 months that you are down to zero immunity. It's slowly starting to drop off. I'm not sure we know what antibody levels, IgG, IgM against the spike protein really at this point is determined that yes, you are immune. But we can detect the antibody levels. We just don't know enough about at what level can we say it's immunity. So the fact that it's dropping off at 6 to 8 months doesn't mean we're all losing any immune response to the virus.
So there's a follow-up question, and it's a little bit on the clinical side for me, so I'll try to do the best I can. The person is asking, Mike, if you're aware of some findings that were reported to the European Society of Cardiology Congress last month that talks about the free-floating spike protein, which damages pericyte cells in the heart. Is that something that you're aware of? And is it something that you want to address, or maybe Marilyn or Jose might be aware of it as well?
I should not address that. I haven't read too much about it. I did hear about it just recently, but I haven't delved into the specifics of that.
Jose?
I can quickly comment on that. Again, I'm not a cardiologist, but I did see that and read that. So I think it's good to understand what they are trying to answer, which is essentially, why is this happening, right? So I don't think that we have full understanding as to why someone who gets the Pfizer vaccine then develops myocarditis. And really, that's the bottom line of what that study is trying to look into, because that's the first step. Once you understand why it is happening and how it is happening, then maybe we can prevent it from happening, and we could also think about ways to treat it. But the message there goes back to what are the risks? When you compare it to, yes, you may have this potential adverse effects if you were to get the vaccine, but that situation is much more common if you were to develop COVID-19 infection. So just remember, myocarditis is part of a complication of COVID-19 as well. It could be because of the virus directly attacking the heart muscles. It could also be that inflammatory phase wherein you have a dysregulated immune response against the virus, and then you develop inflammation in the heart muscles.
And I'll connect that back to side effects too. When people are concerned about the side effects of the vaccine, we know for the most part that everyone is going to have a mild reaction. There might be some people that have something strange or uncorrelated, but we don't know the full extent of a like a COVID infection proper. Maybe even if you're asymptomatic or perhaps you don't get admitted, but there might be some things down the line that the virus did to your body because we don't know everything about it. You could get infected and then it goes, and just like Jose was saying, it could have adverse effects on your cells, causing inflammation and other things that we don't have a good grasp on right now. What we do know is what the mRNA molecule is going to do to jog your immune system so that you can fight it off a little bit better.
Excellent. And on that sort of same point, Marilyn, so you probably are in the best position to be hearing general concerns that people have. So what are you hearing most from people, either who are our employees or other people that are just coming into the pharmacy? What are the concerns that you're hearing the most, and what are the answers to those concerns that you share with people?
I think what I've heard most of is the side effects, which I feel like we've discussed pretty well here. And then that people just want to wait and see. And I would again reiterate that the time for waiting is over. We know that the Delta variant is going to continue to mutate. We know everything that we know about the vaccine so far, and it's not going to overnight all of a sudden change. That's based on good science and evidence that we can definitely peg our hats on. And I would encourage you to trust the experts.
Okay, excellent. So we only have about 5 minutes left before we have to wrap up. And, I think what's important for the people who are on the webinar to know is that we want them to speak with their healthcare provider to get more information and the kind of reassurance specifically for them that they should have. So it's very important for people to reach out. We do want to leave people with the notion that vaccine is the right thing to do to protect themselves, the staff, patients, certainly. But I do want to ask each of you, and it looks like Phil was not able to stay for the full webinar. So I do want to ask each of you, and we'll start with Marilyn, to kind of leave people with 2 or 3 of the most important points that you think are takeaways that people should think about when the webinar is over. So let's start with you, Marilyn.
Sure. Yeah. If you trust the progressive and evidence-based medicine we practice here at DH, you've got to trust the experts and the science that we have at our disposal. I think a questioning mind is very valuable, but in this instance, we really got to look at the numbers and make a decision. So I'd encourage you to take a look at the data that we have, to continue to be curious, but at the end of the day, defer to those who have really looked at the studies and run the analyses and have the PhDs and people that are more qualified than I am to make these judgments, because that's how we practice medicine here at DH. That's how we manage our chronic disease states, and that's how we need to continue fighting COVID.
Excellent. Mike?
Yeah, but very similar to what Marilyn, follow the science, not the social media platforms and the myths such as secret chips in the vaccine. It's amazing how these stories get out there on social media, but really follow the science, visit your healthcare provider, get your questions answered, or the CDC website that has that science as well, and make your decision based on that. And hopefully it will be vaccination.
Excellent. And Jose, you'll have the last word before we wrap up.
Awesome, thank you. I think it's important to understand the why. And the why is really where we are in the pandemic. 18 months out, we are still seeing a surge, and we've tried to see whether we can make it work under our new normal to have a vaccinated population versus an unvaccinated population. And the why really is that even with that quote unquote experiment, we haven't prevented hospitalizations, and we still have people who are at that increased risk of severe disease and death. And that's really the why. Where we are in the pandemic is that we need to be able to reduce hospitalizations. We need to be able to reduce deaths. And what we have just observed is that this cannot be an individual decision. It has to be a decision by the community at large. So I think the second portion of that is that we have to give our credit more to ourselves on the how and when, meaning how are we going to end this pandemic, and when is this pandemic going to be when is this pandemic going to end? And really, that's really up to us as a community. And personally, as we've just shared, I think our best tool in ending this pandemic and moving forward from the pandemic to maybe an endemic state where COVID-19 leads to just mild to asymptomatic infections is really up to us. And we just need to decide as a community that, hey, this is how we're going to do it. And if I had a choice, I would encourage folks listening today that, if you are undecided to, it's now is the time to move forward rather than wait and see that Marilyn had mentioned.
Okay, excellent. All of the details about locations for employees to be able to get vaccinated and the times can be found on the intranet. You can just navigate to the homepage and everything is listed there. And again, just to reiterate, if you have questions after the webinar, please contact the HR info line, which is hrinfoline@hitchcock.org, and they will make sure you get answers to your questions. I want to thank the panelists today. This is their second round. They did one of these last week too, and we hope that each of you who had questions today had them answered and will feel comfortable and confident that getting the vaccine is the right thing to do. But again, please put your questions to the info line if you still have questions and are not yet comfortable. I want to thank everybody for joining us. We hope you found the session valuable and take good care. Thank you all.